Good evening, everyone, and thank you for joining the Cancer Screening for Vulnerable Populations CPD webinar. I'm Lauren Walker, Cancer Management, Screening and Prevention here at the Central and Eastern Sydney PHN, and I'm joined tonight by my colleague Claire Woods, who's the Intellectual Disability Service Navigator, also at Central and Eastern Sydney PHN. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us tonight. I would like to acknowledge people with lived experience of disability, along with their carers and those in the sector that support them. Please note that this webinar will be recorded and will be available on the CESPN YouTube channel within the next few days. Please ensure that you submit your questions to the speakers in the Q&A function throughout the presentation tonight. To view this box, hover over the toolbar at the bottom of your screen. The chat box is also open if you would like to provide any comments throughout the session. The webinar tonight is presented as a component of CESPN's GROW project, which is part of the federally funded Primary Care Enhancement Program. This is a pilot project currently being rolled out across 4 PHNs in Australia. The program aims to give people with intellectual disability better access to appropriate quality health services that meet their needs. As part of the program, this training is designed to improve your knowledge as healthcare providers of how to best support people with intellectual disability. The Refugee Cancer Screening Project is being led by the Cancer Institute of New South Wales, funded by the New South Wales Government. It aims to improve cancer screening awareness in refugee communities from the Middle East and Sub-Saharan Africa through capacity building, research and community engagement. Through this invaluable work, we are grateful to the Institute for supporting this event tonight. There are 2 evaluation surveys to be completed at the end of the session. One will pop up on your screen immediately following the session. This is a short survey that will allow us to issue certificates of attendance. The second is a more detailed post-training evaluation survey that will be sent out with the PowerPoint slides and relevant resources from tonight's information. We really appreciate your feedback on both surveys. I will now introduce our first presenter. Dr. Sita Devaswala is a medical practitioner with over 35 years of clinical experience in the healthcare of people with intellectual disability. Her clinical and research interests include ageing, preventative health, and health outcomes in people with intellectual disability. Sita has been a clinical director of 2 multidisciplinary health services for people with intellectual disability and a senior lecturer in developmental disability health at the University of Sydney, Faculty of Medicine and Health. She is now a part-time senior research fellow at the Department of Developmental Disability Neuropsychiatry at the University of New South Wales, Sydney. Over to you, Sita.
Thank you, Lauren, and thank you to the PHN for inviting me to talk about this really important topic. I'll just get my PowerPoint presentation up. Okay, so this is cancer screening for vulnerable populations, and I'll be talking about people with intellectual disability. So just to refresh everyone's minds what intellectual disability is, people with intellectual disability have difficulties and deficits in intellectual functioning, so that's reasoning, problem solving, abstract thinking, and that's generally assessed by clinical assessment and IQ testing. But there also needs to be, for the definition, as well as deficits in intellectual function, deficits in adaptive functioning. And adaptive functioning is how the person actually survives and functions in everyday life. So how do they manage activities of daily living, such as getting dressed, showering, preparing meals? As the other second component of adaptive functioning is communication, how they communicate with others. And the third is about how they socialize with other people. The onset for intellectual disability should be in the developmental period, which is an administrative definition before the age of 18 years. And this is a DSM-5 definition. So how many people with intellectual disability are there? The figures vary anywhere between 1% and 3%. And in Australia, it's roughly about 2%, which is about the same prevalence of the Indigenous population within Australia. It's important that we remember that the majority of people with intellectual disability live in the community and not in institutions or large residential centres as they are known. When I say they live in the community, they may live independently with some intermittent support. They may live with families, or they may live in group homes with other people and supported by disability support staff. When we look at the mortality and lifespan, we know that mortality rates are higher in this population than in the general population. So a New South Wales data linkage study in 2015 showed that the standardised mortality ratio was 3.15, which means the mortality rates for people with intellectual disability, adjusted for age and gender, were just over 3 times that of the general New South Wales population. Life expectancy is decreased. It is increasing, but it remains less than the general population, and it varies according to the level of intellectual disability, from about 67, 68 years for those with mild intellectual disability to less than 50 years for those with profound intellectual disability. You'll see different figures around this, but roughly that's about the life expectancy. It's probably going to be a little bit more because this was an older study. The main causes of death are cardiovascular disease, cancer, and respiratory illness. When we look at the health status, we know that people with intellectual disability are at risk of having multiple and complex chronic health conditions. Some conditions, such as epilepsy, mental health conditions, gastrointestinal disorders, occur more frequently than in the general population. Sensory impairments with vision and hearing are very high. And then there are other conditions, as you can see there. So multi-morbidity, which is having more than 2 chronic health conditions, occurs at a higher rate and at an earlier age than in the general population. When we look at lifestyle risk factors for cancer, and the cancers that I'm talking about are those that we're talking about tonight, that for which we have national screening, people with intellectual disability have higher prevalence of obesity and overweight than the general populations. The prevalence figures vary, but they're always high, and higher usually than the general population. And we know that obesity and overweight is risk factor for breast cancer and bowel cancer specifically. We know that many people with intellectual disability have poor nutritional quality diets that tend to be of low fiber, high saturated fats, with inadequate fruit and vegetable intake and high intake of processed foods, all of which are risk factors for bowel cancer. They tend to have very low levels of physical activity. One systematic review found that only 9% of adults with intellectual disability reach the minimum physical activity levels. We know that physical activity levels are fairly low in the general community, but they do tend to be lower in this population. So when we look at cancer rates, the rates vary according to the population studied and how the cancers are reported, because having an intellectual disability is not necessarily triggered in many cancer registries. The studies that have been done across the world, they tend to show either lower rates or similar rates for breast, bowel, and cervical cancer in people with intellectual disability. A Western Australian study, it's hard to try and find more recent Australian studies. This is in Western Australia about 20 years ago, show that the breast cancer incidence in women with intellectual disability was less than half of the general population. More recently, there is some evidence of late presentation of breast cancer. And although these are small numbers, this is a study of women who were treated at one hospital with invasive breast cancer. And of all the women with invasive breast cancer, it was found that women with intellectual disability tended to present at an earlier age and at a more advanced stage than other women. Now, talking about cancer-related mortality, and again, these findings are very variable. One systematic review by O'Leary and colleagues noted that the majority of the studies that they reviewed found lower cancer mortality rates in people with intellectual disability, but it was pointed out that most of these studies included children and adults and didn't specifically look at the cancers that we're talking about tonight. A more recent nationwide Dutch study, which was a large data linkage study, which linked the death rates, the death registries with the registry of people with intellectual disability who accessed support services, found that there was a higher rate of deaths due to cancer in people with intellectual disability, with being almost 1.5 times more than the general population. And for the particular cancers we're talking about tonight, within their national screening programs, the rates were again higher than in the general population. So just before I move on to the cancer screening rates, so these studies seem to show that people with intellectual disability have lower rates of cancer and perhaps lower death rates from cancer than in the general population. Now, whether this is because the people with intellectual disability still have a shorter life expectancy, and we know that many cancers are age-related, or whether they're not being detected because of inadequate screening. And that's something that most studies do agree on. So the general Australian population cancer screening participation rates, this is from Australian Institute of Health and Welfare figures. So in Breast Screen Australia participation, that's the proportion of women aged 50 to 74 years screened in a 2-year period. In 2021-22, about half the eligible women participated. For cervical screening program, 68% of eligible women aged 25 to 74 years participated. And in bowel cancer screening program, nationally, there were just under 41%, with slightly more women than men participating. So the breast cancer screening rates in women with intellectual disability, we know, as I said, most studies agree that the screening rates for all these cancers are less than in the general population. In Western Australia, a West Australian study, for example, found that just under 35% of eligible women with intellectual disability had mammography, compared to 54.6% in the general population. A nationwide cohort study of the National Breast Screening Program in Denmark showed that compared to women in the reference group, which is the general population, women with intellectual disability were not screened. 45% of women with intellectual disability were never screened. Sorry, that's the other way around. That's right, compared with women in the reference group. And for those that were fully screened, only 25% were fully screened compared to 62% in the reference group. When we look at the other cancers where the rates are not that easy to find in the literature, this is a study, a Victorian study, where they asked people with intellectual disability or their proxies, who would be the family members or support staff, about their general health. And so it's a big survey just about general health, but some of this also included how many was screened for the cancer. So for bowel cancer screening, it was about roughly the same as in the general population. This is a 2013 study, so I would expect that the figures are probably higher. Cervical cancer screening rates were significantly lower than in the general population, as you can see, under 15% for women with intellectual disability and just over 70% for the general Victorian population. Breast cancer screening rates were also lower, from 55% to 76%. So I now want to move on to the barriers for why the cancer screening rates are so low. And I suppose this can be broken up into the barriers with healthcare providers, barriers with people with intellectual disability, and barriers of support people. So with healthcare providers, it may be that cancer screening is not considered in women with intellectual disability. So with cervical cancer screening, I've often heard it said that that's not necessary because women with intellectual disability are not sexually active. That is not universally the case. And in fact, women with intellectual disability, particularly mild intellectual disability, may well be sexually active and not taking many precautions regarding STIs and so forth. So they're actually at a greater risk. And then there's also the high level of sexual abuse in women with intellectual disability, which often gets unreported. So certainly women with intellectual disability are at risk of developing cervical cancer, and screening is very important. Okay. Now, similarly, the person with intellectual disability may not know about cancer screening. Maybe it's never been raised with them. And the families and disability support staff also may not see this as being relevant to the person that they're supporting. And for the person with intellectual disability themselves, as I said, there may be inadequate knowledge of cancer screening. There may be anxiety of not knowing what the test involves, fear, embarrassment, particularly with mammography and pap smears. They may have certain behaviours of concern, also known as challenging behaviours, and may be resistant to engaging in health procedures. And certainly in our clinics, we certainly see people who are very anxious and are not, they can't be examined, and they may not even come into the consulting room. So that's basically as a result of extreme anxiety. People with intellectual disability also have many sensory disabilities, as previously mentioned, and physical disabilities, which makes them which makes it difficult for them to physically access some of the screening procedures. Then there are communication barriers that if they don't have the knowledge and if they can't communicate what questions to ask, if they can't communicate that they are anxious about procedures, then that makes it difficult. Often it may be that the capacity for the person with intellectual disability to consent to the screening procedure is not clear. And the other reason is that many of the screening programs identify people to invite for screening through the electoral roll. And there would be a significant proportion of people with intellectual disability who, excuse me, may not be on the electoral roll, so they're not invited. So what helps to facilitate screening in this population? Firstly, it's about providing information in a format that the person can understand and is suitable to their needs. So if the person cannot comprehend verbal instructions, may need to be provided in other ways. Information needs to be provided to family and disability support staff. In some cases, support from family and disability staff may be required to help the person with the screening procedures. The use of reasonable adjustments, which I'll talk about in greater detail in a minute, and the need to, and also clarifying consent is very important. Okay. So one of the other things that healthcare providers can do can make sure that screening is included in the person's healthcare plan. Now, for people with intellectual disability, there is a specially designed healthcare plan called the CHAP, or the Comprehensive Healthcare Program. And that's been licensed by the federal government, and it's free to download for anybody through the website. And this is a booklet that prompts the primary care physician to do certain health checks for conditions that we know are very common in people with intellectual disability, as well as other routine health checks, prompts them to do immunizations, and will also prompt the primary care physician to do the routine screening. And that would include cancer screening, as well as regular screening of hearing and vision, which needs to be done. So that's something that you can have a look at very easily by downloading from the Australian government website. Now, accessible information about screening. I'm getting most of this information is available through the Family Planning New South Wales. They have an excellent disability resources section, and many of you may already know that. So for the person with intellectual disability, there are easy English sheets, pictures, videos, and social stories about cancer screening. So this particular section of the website is called Just Checking. So there are social story booklets and videos on cervical, breast, and bowel cancer screening. For the person who supports the person with intellectual disability, there's information. This is for families and disability staff and others who might support the person to access screening. There's information about the screening programs and a conversation planning template. So how do you actually talk to the person about what cancers are and what the screening involves and other details. So this is support for the support person, if you like. And for the healthcare practitioners, there are resources as well. And one of them especially is about a supported decision-making tool. So these are the 3 main booklets about cancer screening. So Betty's story is Betty has cervical screening test. Lisa's story is about Lisa having a mammogram, and Bob's story about Bob having a bowel screening test. So they're booklets in plain English and pictures. So the person who's being supported by family or support staff or the GP or other health professionals can go through the booklet and explain what's actually happening. Now, what I would like to do is see if I can bring this up to show you one of the booklets. Not that easy, is it? Just excuse me for a sec. Okay, so this is Lisa's story.
We can't quite see the
Can't see it?
not yet. We can see your folders.
Oh dear. Okay. Share. Okay. How about now?
Yeah, that's come up now.
Yep. So this is Lisa's story. So it's about having a mammogram. So Lisa's turned 15, gets a letter from Breast Screen, and her mother, Nancy, is going through the explanation with her. And it's about ringing to make an appointment. It's turning up at Breast Screen. Let's go through this fairly quickly. So, and then this shows the woman, this is what happens when you go in for a mammogram. Of getting changed, taking off the bra, puts a shirt back on. And actually shows what actually happens with the mammogram and how it might be a bit uncomfortable. So this is a nice way of showing the woman what happens in a mammogram. So it becomes a lot more, it removes a lot of the fear. So that's that. And then there are similar booklets for, sorry, I'll just get my PowerPoint back on. And there are similar booklets for, sorry, I'm just trying to get the full screen. Okay, similar booklets for bowel cancer and cervical screening tests. Okay. And the links I've given also shows you the support person's tool and the health practitioner's resources. So that's all on the New South Wales family planning website. Now, I talked about reasonable adjustments, and these are adjustments that are made to remove barriers or provide additional support for people with intellectual disability to access healthcare. These, there are a number of things we can talk about are reasonable adjustments, but they need to be tailored to the individuals. So considering what supports the person needs, consider sensory issues. Any procedure should be in a calm, slow manner, explaining at each step what is to happen, so that if you're doing cervical screening, a pap test, and explaining at each section what's to happen, and to reassure the person that they can ask to stop the procedure at any time, so they actually have control. Communication, using different communication methods, and I'll talk a little bit more about communication in a minute. So you can use alternative communication methods if the person doesn't speak. The environment should be a quiet space and be physically accessible. Calm, quiet space may need things like an adjustable height bed. A hoist may be needed for someone with physical disability, allowing sufficient time for the procedure to take place, and may need to adapt or use alternative procedures. So with cervical screening, there is now, you can do self-collection. And if the woman is able to do that and has been shown how to do it, then that might be a better alternative for some women. In others who are unable to do that or are anxious about it, either the healthcare practitioner does it or has support with a disability support staff or family member to self-collect. Might consider that the woman might need alternative positions instead of the usual prone supine position for cervical screening. May need to use different size speculums. For a woman who can't tolerate mammogram, may need to consider things like breast ultrasound or just breast examination, which obviously are not going to be as satisfactory, but they may be a stepping stone to ultimately leading to mammography if the woman becomes more comfortable and familiar with breast examination and ultrasound. Appointment timing is really important. Because you'll need time to explain the procedure, make sure it's understood, may need a longer appointment or several short appointments. So the first appointment just to discuss, and the second appointment to do the cervical screening, if it's that. Obviously with mammogram and bowel cancer screening, they're different. Sometimes it helps to have the last appointment of the day, so the person's not sitting around waiting, and their anxiety can build up if they have to wait. That's for some people. Where it's necessary, it's important. It is good to involve support persons. So support staff, I certainly know for people living in disability group homes, that I was always quite surprised as the number of times the person would turn up for their health assessment with the support staff and they already have done their bowel cancer screen, because the support staff actually collect the sample. So that makes it much easier. Again, they can also help with at mammography or self-collection, a cervical cancer screen. Providing easy information in pictures or languages, and the examples that I've just shown you now. With communication, it's really important to talk directly to the person and not just the support person who's with them. Use short sentences, simple language, one idea at a time. At each stage, it's important to check understanding by asking them what they understand by what you've just said, or ask them to repeat what you've just said. And it's usually almost always the case that a person who can't say very much usually understands a lot more than they're able to express. A person who's non-verbal may use other forms of communication. So it's really important to ask how they communicate. Augmentative and alternative communication is the terminology for all other forms of communication. So that could be using pictures, using signs, real objects, videos, or electronic communication devices. And some of them are quite sophisticated, and there are iPad apps now that help with the communication. So with the consultation, important to explain not only the reason for screening, what it involves, but also what happens if it's a positive test. What does it mean? And for them to understand that if there is a positive test, that additional procedures may be required. I want to talk now about consent and supported decision making, because this is really important, understanding what a test is and to give informed consent for the screening to go ahead. With any type of medical decision making or any other types of decision making, the first thing is to presume the person has capacity for consent. And it's also important to remember that the capacity for consent is situation specific. A person might be able to consent to one thing, say, for example, consenting to take an antibiotic for a chest infection, but they may not be able to consent to something more complex medical procedure. So the person has capacity, if they can, understand the facts and choices of the decision, weigh up the consequences, and communicate the decision after having understood and weighed up. Now, there's a website with the Departments of Communities and Justice, New South Wales government website, which has an excellent capacity toolkit, which you can download. And that goes through in detail about how to assess capacity. It won't be just for people with intellectual disability. It can be for other patients that you have. And there's also an e-learning module there which you can access. Now, supported decision making, which is what you sometimes need to provide the support that is a reasonable adjustment to allow the person to make the particular decision. So the reasonable adjustments I just talked about, such as providing information in an understandable manner, communicating slowly, all those help with supported decision making for the person. If a person does not, however, have capacity for consent, substitute decision making may be required. Now, I'm talking about the New South Wales jurisdiction, and I apologise for people who are joining this webinar from interstate, but there will be similar legislation in other jurisdictions. In New South Wales, the person responsible is someone who can do the substitute decision making. And this is someone who has a close and continuing relationship with the person with intellectual disability. And there's a hierarchy for this. Firstly, a legally appointed guardian, if there is one, can provide the decision. If there's no legal guardian, then it's a spouse or de facto. If there is no spouse or de facto, then an unpaid carer of the person, someone providing informal support. If there is no carer, then a close friend or relative. So they're the people who can provide substitute decision making in some instances. In other instances, only the tribunal can provide that. But for most decisions, certainly medical decisions, a person responsible can provide that consent. And it's really important to know that disability support staff or any other person who's paid to provide support cannot provide consent legally. So the role of primary care providers is very important with cancer screening, because primary care healthcare providers are aware of the health and living circumstances of the person. They're aware of any barriers such as anxiety, communication difficulties, other impairments, the person's capacity for consent. They're able to consider if the benefits of screening outweighs the negative effects of anxiety and distress. So although we encourage cancer screening in everybody, there will be some instances where the levels of anxiety make it so difficult that you would need sedation to be able to do the procedure. Particularly, I'm thinking about pap smears. And in that case, you would need to weigh up the risks and benefits for that individual. So primary healthcare providers who know their patients well are in a good position to actually help the person come to that kind of decision if the benefits outweigh the negative effects. To provide alternative options if screening is required. To advise and provide reasonable adjustments to facilitate screening, whether it's in your own doing cervical screening or whether it's to inform breast screen about the adjustments that might be necessary. Provide information adjusted to the individual's understanding about screening and strategies to manage anxiety and strategies to adjust to other impairments. So in summary, screen-detected cancer rates in people with intellectual disability are similar to or less than those seen in the general population. The numbers are low, but there is some evidence of late presentation of, well, in this particular instance of breast cancer. We just don't have the numbers for other cancers. Screening rates for breast, cervical and bowel cancers are low compared to the general population, and this is due to a number of barriers, including knowledge, limited communication, anxiety, and strategies to overcome the barriers include the use of reasonable adjustments. Really important, making screening a part of the person's healthcare plan so that you're reminded at each review that screening is required, and clarifying consent. So primary healthcare providers are uniquely placed to facilitate screening. I put here some of the resources. That's the Family Planning New South Wales Just Checking website, the Capacity Toolkit, and the Guardianship Division of the New South Wales Civil Administrative Tribunal that gives them more information about the person responsible and the requirements for consent to medical or dental treatment. And then some references. Thank you. Okay. Oh, it's gone dark. Let me just turn the light.
Yes, straight on that timing. Thank you very much, Sita. I'll give people just a moment to ask some questions in the Q&A. I think we've got one come up now. Okay, so how do we explain to family members who think their child is not sexually active and that a cervical screen is not needed, that we would still recommend the screen, knowing that we are aware of high rates of sexual abuse in this population? Comment is often the family members don't want to think of their child as having had sex, talking about patients who can't communicate this themselves.
That's very true. And yes, they still might see their child as still a little child. I think that's not an easy question to answer. It depends whether you are able to communicate with the woman herself. And it's a question of whether you suspect that there has been any sexual abuse. I think it's something that you can't deal in one consultation. I think you have to get trust of the family and just gradually explain maybe that there are risks of sexual abuse. And unless they're absolutely certain there hasn't been any, their daughter's not been sexually active. I think it's, I have come across families that are like that, and I think you just have to take it very gradually. There's no easy answer around that. Sorry. Yeah.
Thank you. I had a question as well. You mentioned towards the beginning of your presentation that it's been difficult to find more recent Australian studies or evidence. Is that, do you think, because of the COVID pandemic? And if so, has it been similar in other countries, or are there other reasons for that?
Data about mortality rates and cancer rates, you mean?
Yes, I think that's what you referred to, saying that was, a lack of recent Australian data.
Yeah, well, the studies just haven't been done. I don't think it's because of COVID, and I think it's a bit difficult to do that. Having said that, I should put a plug in for at 3DN, which is where I work now. They are doing some data linkage study to look at screening. But you really need to do, most of the studies are on small populations because people with intellectual disability is a small percentage of the population. So the only way you can do that is by taking the whole state population or national population and doing some data linkage. And that's where those studies have been done overseas, looking at whole populations. Yeah.
Okay.
And as
Thank
to my
you.
knowledge, I don't think in the cancer registry, people with intellectual disability are identified. Maybe Sheetal can tell us that from the Cancer Institute. Yeah.
Okay, and before I do introduce Sheetal to present, there's one final question in the Q&A. How would you approach a GP who has categorically refused to discuss the possibility of completing cervical screening? In these circumstances also, families tend to follow the GP's opinion, regardless of education that has been provided. One family even quoted that the GP knows best.
All right. Well, again, that decision about whether you weigh up whether the woman would benefit from her cervical screening, if whoever's asking the question feels that the woman does need cervical screening, then there are other facilities. But you have to bring the family around as well, don't you? It's very similar to before. I mean, it's very easy to say go and find another GP. And provide some facts and figures for the GP. But if the family trusts that particular GP, and it depends very much, is a person living in a group home? Are they living with the family? I think you have to just talk to the family a bit more and see if you can find an alternative provider. Yeah.
Well, thank you very much.
Sorry, I was just going to say, and also find out why is the GP refusing? Is it too difficult or doesn't believe in it? But then some of those adjustments that I talked about may make it a bit easier for the GP.
It's true.
Yeah. Okay.
Oh, well, thank you very, very much, Sita, and thank you for those questions as well. So we'll now introduce our second presenter for the evening. With 20 years of experience in both multicultural and refugee sectors, Sheetal Shalom has held various roles in the areas of policy development, stakeholder engagement, and government relations. Sheetal currently leads the multicultural program at the Cancer Institute of New South Wales, where she provides strategic advice to institute staff and facilitates key partnerships to improve cancer outcomes for the state's culturally diverse communities. Prior to her stint in the government sector, Sheetal spent close to 7 years in the settlement sector, coordinating programs for new and emerging communities in the Blacktown area. Sheetal has completed a Master of Arts degree from the School of Cultural Histories and Futures on a scholarship and holds a bachelor's degree in psychology and English literature. She is particularly passionate about refugee health and keenly interested in ethics and social responsibility. And I have had the pleasure of seeing this up close over the number of years that we have been working together, Sheetal. And she occasionally dabbles in filmmaking and writing as well. Over to you, Sheetal.
Thank you, Lauren. Thanks for that introduction. I have my sincere thanks to Central Eastern Sydney Primary Health Network, and particularly Lauren Walker for inviting me today. And I know you've all had a long day, so let me set the scene first. So I will share my slides in a minute. Is this visible?
Perfect.
Lauren?
Thank you.
Thank you. So yes, thank you very much for your time today. would like to set the scene for what's coming up for the next 30 minutes. You've all had a long day, and so we'll probably finish up very quickly with having a look at the demographics of New South Wales multicultural communities and refugee communities in our state. Then we will be looking at some cancer data, and then we will delve into barriers and enablers similar to what Sita presented for those with intellectual disability. And finally, we'll be exploring what tools and resources are available to support your great work with migrant and refugee population. So I'd like to acknowledge the traditional custodians of the land on which we work and live. Today I'm joining you from the Darug land, and I'd also like to recognize their continuing connection to land, water, and community. I pay my respects to elders past and present. Also, I'd like to acknowledge the lived experience of our consumers and patients who have been impacted by cancer, their carers, loved ones, and supporters. And finally, I also would like to acknowledge the great care you provide to your patients as primary care providers. Um, the You're a critical point of contact within the health system for our migrant communities. And it is with sincere thanks and gratitude on behalf of the Cancer Institute, I'd like to acknowledge your great work in providing equity of care. Let's begin with this slide. It's a quote from a famous Canadian physician. And if I can read it out, it is much more important to know what sort of a patient has a disease than what sort of a disease a patient has. It's a really great segue to to the notion of person-centered care, and it is, I guess, a real good reflection about the needs of our multicultural and refugee populations, the cultural complexity that they bring, and also their spiritual, religious settlements, social needs, and its interplay with the primary care sector. So this is a bird's eye view of our multicultural population. As of 2021 census, 29.3% of our population was born overseas, and 26.6% speak a language other than English. So I think for New South Wales, we are a microcosm of the macrocosm. We have people coming from so many different birthplaces, and in spite of the COVID shutdown, our diversity still increased. And I can tell you a staggering statistic, and that is that 91% of people in Greater Sydney spoke a language other than English. Yes, so it's 91%. Regional New South Wales also has a rapidly growing community driven by employment and refugee settlement. Many factors are many factors are associated with this migration, and like I mentioned, the refugee settlement is the most important thing. And also, cancer care for these communities can often be complex, also because of the great distances in regional and rural areas. Now, let's have a look at the slide to understand our overseas born population. So as you can see, United Kingdom is on the top there, followed closely by those that are born in China, India, New Zealand, Philippines, Vietnam, Nepal, Lebanon, Iraq, and South Korea. Now, the story of Nepal is unlike any other community. Before 2016, there were not many Nepalese people in New South Wales, but the population has doubled. So our primary care providers and GPs, particularly in the area of Georges River, Cumberland, and Bayside councils, will be encountering patients of Nepalese background. And this cohort mainly sits within the cervical screening cohort of 25 to 74 years. Here are the emerging and declining birthplaces. So no surprises there with emerging birthplaces, which is on the left of the screen. So we have India, Nepal, Philippines, and all those countries. But I'd like to draw your attention to the bottom three, which is, so we have people born in Brazil, Malaysia, and Syria now creeping into the top 10 emerging communities. The Brazilian community is mainly in the 25 to 74 range. They're all working age adults and live in and reside in northern beaches, Randwick areas. So GPs and other primary care providers in that area might be encountering patients who are born in Brazil. On the right are declining birthplaces. Patients in this category are mainly established Europeans who have migrated post-World War II. It is likely that you'll see more cancers in this group as they are aging. And as you know, there's direct correlation between age and cancer. They might also have unique language needs because as people grow older, they tend to forget the language that they've learned and revert to their native language. This slide is about the top 10 communities who speak a language other than English in New South Wales. It does match up to the birthplaces. Of course, UK is not part of this, so we don't have English on the slide. These languages are for those groups that speak a language other than English. So we have Mandarin, Arabic, and Cantonese in the top 3. I would like to point out something about the Arabic language speaking group. Arabic is the official language in 24 sovereign states, and the population characteristic for this particular group are vastly different when it comes to cancer screening. So female patients who speak Arabic from South Sudan will screen very differently from your female patients from Saudi Arabia or from Iraq. In the census, there is a question around language proficiency. The individual completing the census, this particular question, self-assesses and rates if they speak English very well, not well, or not at all. The top 10 here have 40% of their population who have reported that they have low English language proficiency, a very important factor to know in terms of using interpreters. Please note, I'd like to draw your attention to the Assyrian community, which is in the 10th in the largest populations having poor English language proficiency. The Assyrian community is mainly residing in southwestern Sydney area, actually predominantly in that area. They have significant beliefs around cancer and therefore might require dedicated efforts from the primary care sector to encourage them to screen for bowel, breast, and cervical cancers. Other measures of cultural diversity include religion. So in the top 10 are the two Christian denominations, the Catholic and the Anglicans, followed far behind by Islam. There are studies showing disparity in screening rates of women practicing different religions. That is something that primary care providers probably will have to navigate to improve cancer screening participation rates in those communities. Here's a top-level view of the multicultural communities across the state. The catchment is local health district, which means some of that catchment aligns with primary health network catchments. So you can see that the southwestern Sydney is quite diverse at 46.4% that have people speaking a language other than English. That's pretty significant. In areas like Fairfield, that actually goes up to about 70%. Western Sydney, so this area which covers the Auburn, Cumberland, and the Blacktown areas have 51% who speak a language other than English. Our regional areas are also becoming more diverse. Illawarra Shoalhaven is probably the most diverse regional and rural catchment. And once again, this is driven by the refugee settlement. So now I'd like to introduce you some information regarding humanitarian entrance. As you're aware, Australia is a signatory to the United Nations Refugee Convention. As a result, we settle a proportion of humanitarian entrance as part of our humanitarian settlement program. New South Wales does take a lion's share of these humanitarian entrants, and what we know, of course, is that people from refugee background have higher rates of physical and mental issues. They have lower rates of cancer screening and experience significant barriers to accessing healthcare. I've just included a quote here from the Royal Australian College of General Practitioners, which says, and the quote is that they support equity of access to confidential quality healthcare for all people from a refugee background, including people seeking asylum. The world map there are hotspots from where our refugees are settling in New South Wales. I would also just like to share with you this particular new study that was released only last week by the Australian Institute of Health and Welfare. And the study showed that almost 9 in 10 humanitarian entrants attended a GP at least once in 2021, showing that incredible care that you're providing to our refugees and humanitarian entrants, and that 99% of these attendances were bulk billed. The same study showed that liver cancer had high mortality rates in humanitarian population, with lung cancer as one of the leading causes of death, both in males and females. This slide really provides you further information regarding our humanitarian entrants. The bullet points there is a list of the languages spoken by our humanitarian entrants, and that's just a very small list. So they include Dari, Assyrian, Pashto, Kinyarwanda, Kurdish, Kurmanji. The reason why I've listed them is to tell you that these are smaller and rarer languages, and interpreters might be not as readily available for those languages. So, and next to that, I've also listed some of the visa categories under which refugees arrive to New South Wales. Most of those people who arrive on those visa categories would be eligible for Medicare. The New South Wales Refugee Health Service is a statewide service that provides a range of clinical services and medical assessments for those that are on asylum seeker visas, and there are a number of asylum seeker bridging visas with different kinds of access. So that I think is something that you will encounter as you're providing care for those that are claiming asylum in New South Wales. So after all this, I'm sure you are quite interested in understanding the cancer screening participation rates in our culturally and linguistically diverse communities, including refugee communities. So I will share that with you over the next few slides. The breast screening participation rates for eligible women from culturally and linguistically diverse background from 50 to 74 is 37.8% as of August 23. That's 37.8%, which is fairly low. People who spoke a language other than English had a lower bowel screening participation rate at 25 to 32%. And then for cervical screening, we don't have data for different language groups. What we know is that 61% screened between 2018 to 2021, and we know that barriers in relation to cervical screening. So back to that census data, here is a snapshot of those language groups which might require a dedicated effort on from the primary care sector to improve cancer screening participation rates. So the cohorts are quite similar for breast and bowel, because we are looking at 50 to 74, and therefore you'll see some the two tables matching. Um, uh, in terms of language groups. The only difference is with cervical screening. Here we have a more Filipino and Hindi now are in the top 6. The Hindi speaking whereas of the Hindi speaking population. Sita, she was talking about there are some similarities of communities. So they include, low literacy, the unavailability, trauma, low awareness of cancer screening, the care pathways, and also the other barrier might be that some of them are originating from countries where screening is not routinely offered. So here are some of the points. I've just put them. I won't talk about all of them. What culturally responsive care would look like, and what are some of the considerations. I'll just talk about 2 things, and one is the lack of medical, the point around lack of medical records. Um, the years ago, as Lauren mentioned, I worked in Blacktown with newly arrived refugees, particularly unaccompanied minors who were arriving here with no previous legal records, which means that we couldn't determine their actual age, and they required further investigations like bone density and also dental checks to determine the age. And as you can imagine, this is getting the chronological age is quite important, so that they can access the screening programs at the right time. So that's one thing I'd like to share. And the other thing I'd like to share about health literacy is one thing, but cancer literacy is another thing. It sits on a spectrum with messages around do not smoke, stay healthy, walk, or eat healthy, being at one end of the cancer spectrum to the other end, which has messages around IFOBT test and human papilloma virus. So it is quite hard for our migrant populations to comprehend that information. I spoke about beliefs around cancer. It is, we have found, we are undertaking a study within the Cancer Institute, and we know that the beliefs and stigma around cancer is a real barrier. It is a barrier to participating in screening. It leads to later detection of cancer and poor prognosis. I've captured here some of the things that we have found around cancer. Uh, we um, uh, we undertook quite a broad literature search, and we found quite phenomenal beliefs around cancer, around karma, and talking about cancer will manifest it, cancer is contagious, and etc. And I can just imagine how difficult it would be for you as primary care providers to deal with that and provide care for our migrant and refugee population. So here is just some what we found in terms of intersection for those beliefs, and I'm quite happy to share more information through the Central East Sydney PHN at a later time. So after all that, here's a landscape. I'm sure you've seen this. 1 in 2 people will be diagnosed with cancer in their lifetime. 900 people per week are diagnosed with cancer, and 413 people will die from cancer each week. So that's pretty, ominous to hear that. So the Cancer Institute undertook a country of birth cancer data study. We looked at some linkage. We linked data, and we looked at 3 major cancers, that is breast, colorectal, and lung cancer. And these cancers were diagnosed from 2003 to 2016. We looked at stage, treatment, and survival rates for top countries of birth that included Australia, Germany, Greece, Italy, Lebanon, New Zealand, Philippines, UK, and Vietnam. And I have got the next 3 slides that show some major findings, and I'll just hone in on one per slide. So for the breast cancer, compared with Australia-born women born in mainland China, the Philippines, Vietnam, and Lebanon were younger at diagnosis, which probably really brings home the fact that we need to prompt breast screening with these groups earlier, much earlier. than the eligible age, which is 50. The next one is around our findings around colorectal cancer. What we found is that the socioeconomic disadvantage appeared more pronounced in those born in Lebanon and Philippines and Vietnam. So those with colorectal cancer were in those areas that had quite a social disadvantage. And also what we found is that for both colon and rectal cancers, people born in Philippines, Vietnam, Lebanon, and New Zealand, they were younger at diagnosis. Finally, for lung cancer, we know that the lung cancer screening is not too far away, and you will once again be, um, there'll be a call of duty, and you have a very significant role to play in terms of lung cancer screening. So I'd like to share with you through our country of birth, what we found was that there was a strong male predominance for people born in Greece, Italy, and Lebanon for lung cancers, and these are non-small cell lung cancers, and also that once again those born in Philippines, New Zealand, or Vietnam tended to be younger at diagnosis. So after presenting all that information, I'd like to just pause and thank you on behalf of the Cancer Institute New South Wales for all the work that you do with our migrant population. We acknowledge the primary sector's enormous contribution in improving cancer outcomes of our communities. The biggest motivational factor for people to participate in cancer screening in primary care is primary care providers is the endorsement from primary care providers. Cancer management can be also quite complex, and you are called upon for a lot in terms of that care coordination, referrals to specialists, and also management of comorbidities and secondary prevention. So once again, we thank you for your work. There are new guidelines in bowel and cervical screening whereby women can now self-collect, which Sita pointed out earlier. So they can self-collect their cervical screening samples, and GPs now can distribute a bowel cancer screening kit to their patients, which is likely to improve cancer screening participation rates in our communities. We also, on behalf of the Cancer Institute, we also acknowledge the challenges you face to meet the needs of our rapidly changing demographics. And so the next few slides, I'll share with you some tools and resources that are available at your disposal to make your work lighter. I have been talking all along about the Cancer Institute New South Wales. I just want to share with you a little bit about who we are and what we do. So for those that are not familiar, the Cancer Institute is a state government agency that provides strategic direction for cancer control across cancer prevention, early detection, treatment, and cancer research. Underpinning the Cancer Institute's work are initiatives to improve cancer outcomes of our multicultural communities. And key to the success of the Institute's work are partnerships and collaboration, like the ones that we have with primary health networks, and particularly Central Eastern Sydney PHN, the hosts for this event, and also the primary care providers. So I'd like to extend my thanks to the primary health networks once again for the work that they do. So to support your great work, we have developed a cancer control quality improvement toolkit that can be built into your practices or health service. It has useful modules utilizing data and systems to improve participation rates in national cancer screening programs and preventative programs. Interweaved in the tool is person-centered care. So you will find information on refugee health assessments. So the template is on the screen, which uses Medicare items like 701, 703, etc. It also contains information on doctor's priority line. This is a free service to GPs and medical specialists, and also allied health professionals to communicate with patients who are not English proficient. I have to point out that on each of the slides, I've include a reference, and I believe these slides will be made available for you at a later time, so you can delve a little bit more deeply into these tools. We also have a number of resources that are in diverse languages, more than 40 languages, and the in-language resources really are across the cancer spectrum, from cancer prevention to cancer screening, clinical trials, as well as patient also resources to support patients, and they can also be used as a teach-back tool, if you like, with your patients, because they have a lot of pictures and also are quite written in very simple language. The CanRefer is a free online directory. That's available for you all when you refer your patients to specialists. It aligns with optimal care pathways. The wonderful thing about it is that you can refer to specialists who speak a language other than English, so that the search engine is available within that tool. And also you can find out where clinical trials are available, so you can share that with your patients. This is my last slide. The patient information web page is nestled within the Cancer Institute website. There's a lot of information available here. There are checklists for patients. There is information there so they can understand what is going to happen once they're diagnosed with cancer. And information is available in 8 community languages, the dominant community languages, and there's also information that is available on multimedia formats like audio, video, so people can just listen to it while they're driving to their appointments, and this the link is available on the website, and you can refer to this and pass the information to your patients who speak those languages. And that brings me to the end of the presentation. I hope I've been able to share something new with you today. Thank you for your attention. There's the Cancer Institute website URL, and if you would like to contact me at a later stage, my email address is on the slide, and so is my phone number. And of course, you can contact me through Lauren Walker or through other Central Eastern Sydney PHN staff. Thank you very much.
Thank you so much, Chital. We really appreciate such an engaging and passionate presentation with a lot of information there. I will give everyone a moment to see if there's any questions that come through. In the meantime, I was wondering, are there any state government or federal government policies supporting asylum seekers at the moment?
Yes, actually, there are. There was a New South Wales health policy that was established only about 3 years ago, and this is for those asylum seekers who are not Medicare eligible. So in New South Wales, we take a human rights approach to healthcare. So I can share that link with you, Lauren. Actually, I can put it up on the chat just as we are talking. So yes, there is a policy that is available for our primary care providers.
That is good to hear. Thank you very much. We'll make sure that goes out in the information following the event. So I don't think anything's come through, but thank you again, Chital, and for sharing your contact details as well. So all of our attendees know tonight that they can get in contact with yourself, or of course through the PHN, through Claire or myself. So thank you to both Sita and Chital and everyone for attending, for participating in tonight's webinar. A reminder to please complete the online survey that will pop up in your web browser, as well as the post-training survey that will be emailed to you all following the session. So we look forward to seeing you all online soon. Thank you. Take care.